welcome and thank you for being here today. I'm Navneet Singh, your host for this webinar. I know that today's topic might bring up a number of questions from you. So you may type your questions in chat box and I want to let you know that we will address as many as we can in the time we have today. And I welcome and request Professor Dr. Vijayalakshmi Subramaniam to start this session. Welcome, ma'am. Over to you.
Thank you very much, Mr. Navneet, and good evening to you and all the trainees who have joined us for this webinar on the clinical evaluation of vertigo. So, I will be giving you a brief overview on the approach to evaluation of a patient with vertigo through this and how to take a history and to do the clinical examination of a person who presents with dizziness. So, dizziness, as we all know, is one of the commonest presenting symptoms with which a patient might come to the ENT OPD, but it's equally a confusing symptom and at the same time pretty much challenging for the otorhinolaryngologist. So, and the differential diagnosis of this condition is very broad, and there are a lot of common etiologies which account, but difficult to arrive at a diagnosis without doing a proper clinical evaluation. Now, dizziness actually refers to the various abnormal sensations which relate to the perceptions of the body's relationship in space, and a person who presents with dizziness may come to us with either a feeling of rotation, a feeling of spinning, non-rotatory swaying, lightheadedness, faintness, weakness, or unsteadiness. There can also be people presenting to us with blurring of vision, feelings of unreality, syncope, etc. As I said earlier, dizziness is a very common complaint, the overall incidence being about 5 to 10%, and 40% of the cases are seen in those who are aged above 40 years, and it's more common in women and pretty much predominant in senior citizens. Now, vertigo is an illusion of movement. We need to understand the difference between vertigo and ataxia. Ataxia is an inability to coordinate movements. This could be inability to coordinate movements while walking or inability to coordinate movements of the extremities. So one feels as if drunk. Now, dizziness is a very, very non-specific term, and it encompasses the lightheadedness, swimming sensation inside the head, rotatory feeling, swaying sensation. So many things are referred to as dizziness, and different people have different meanings and different connotations to the word dizziness. So dizziness could either mean vertigo, it could mean weakness. Patient can even say, I feel anemic. It could be a feeling of syncope or pre-syncope. I mean, where the person will say, I have a blackout. It could be giddiness. It could be saying, I feel all day low or depressed. Patient can present to us with anxiety or unsteadiness. But people with vertigo predominantly present with a rotatory feeling, and the syncope and pre-syncope category of patients usually have that feeling of blackout. We will get into the details of these in today's session. There are 4 types of dizziness: vertigo, disequilibrium, lightheadedness, and pre-syncope. So we just get into the definitions that may be described by a dizzy patient. Now, a sensation of perturbed spatial orientation is dizziness, and This is a term that can be applied to a multitude of different symptoms that cause disturbances in spatial perception. Vertigo is an illusion of the self, or it could be an environmental rotation, but it is usually due to vestibular lesions. Disequilibrium or imbalance is a sensation of being off balance, or a sensation of being unstable, and it may be caused by various problems. Oscillopsia is an illusion of oscillation of the visual environment. While gait ataxia may be described as imbalance or appearing drunk while moving, and this gait ataxia could be a cerebellar ataxia or it could be a sensory ataxia. Syncope and presyncope are usually feelings of faintness or near faintness, and they are usually related to the cardiovascular system disorders or autonomic nervous system disorders. And syncope or presyncope could be orthostatic, could be related, the faintness could be related to the change in position, in which case one should suspect orthostatic hypotension. Going into the definition of vertigo. Vertigo is a sensation of rotation or imbalance of oneself or one's surroundings, and this rotation can be in any plane. Rotation of oneself, as you all know, is called as subjective vertigo, whereas the rotation of one's surroundings is called objective vertigo. In syncope and presyncope, there is either a transient or an impending loss of consciousness, and one has to remember that there is a loss of postural tone. So syncope is always associated with a loss of postural tone. Disequilibrium is a feeling of unsteadiness, imbalance, or a sensation of floating while walking. There will be people who will come to us saying that I feel as if I'm walking in the air. So that is because of disequilibrium, and this is quite common in the elderly. The other thing is lightheadedness. So an approach given by Martin Samuels on asking the person what he or she means when they say uh, that when they present with complaints of dizziness. So what do you mean dizzy? When you ask that question, what do you mean dizzy? If the person says that I feel I might faint, I am giddy, or I am lightheaded, then this could be something like a syncope or a presyncope, and it is usually due to cardiovascular disorders, which include orthostatic hypotension, cardiac arrhythmias, hypersensitive carotid sinus, vasodepressor spells, that is the vasovagal syncope, and it could also be because of the valvular heart disease, particularly aortic stenosis. Now, if the person says, I might fall, and that feeling of fall is usually referred to as disequilibrium, and this is usually related to non-vestibular neurologic disorders. And these could be either cerebellar disorders, multiple sensory or multiple sensory deficits. If the person says, I'm tilting, or I feel I'm rocking, or the room is spinning, then that is vertigo, and usually because of vestibular disorders. And vestibular disorders could be the peripheral vestibular disorders or central vestibular disorders. And when it comes to peripheral vestibular disorders, there could also be a cochlear lesion or a retrocochlear lesion which is causing the problem. The psychiatric disorders usually come under the category of ill-defined lightheadedness and are usually related to anxiety or depression. Is the slide up?
Yes.
So now vertigo, we just talked about, there could be peripheral causes or central causes. So peripheral vertigo is caused by lesions of the vestibular end organs and the vestibular nerve, and it accounts for 85% of all cases of vertigo. Central vertigo is caused by lesions of the central nervous system and accounts for 15% of all cases. Now, the central causes for vertigo, it's very easy to remember this, and that's why I have put it, though it is not all encompassing, but it's easy to remember this. So it could be due to vascular causes, epilepsy, and it could be not just because of the disease per se, but also because of its treatment. It could be because of road traffic accidents, so causing head trauma, concussion, tumors of the brainstem, the fourth ventricle, and the cerebellum, infections which include meningitis and encephalitis, glial diseases like multiple sclerosis, and others which could be Parkinsonism or it could be psychogenic vertigo. Now, the vascular causes for vertigo include vertebrobasilar insufficiency, the Wallenberg's lateral medullary syndrome, hypertension, and basilar migraine. Wallenberg's lateral medullary syndrome is usually caused by an infarction in the territory supplied by the posterior inferior cerebellar artery, which is referred to as the pica, and it is characterized by ipsilateral ataxia, vertigo, nystagmus, and diplopia, loss of touch, pain, and temperature on the ipsilateral part of the face and contralateral part of the body. The person will also have dysphagia, hoarseness, and there will be a reduction in the gag reflex, and there will be Horner syndrome on the side of the lesion. The commonest of the peripheral causes for vertigo is benign paroxysmal positional vertigo, followed by Meniere's disease, vestibular neuronitis, labyrinthitis. Then you have the ototoxic drugs, which could be vestibulotoxic, vestibular schwannoma, perilimb fistula. Apart from this, temporal bone fractures, barotrauma, cochlear otosclerosis, autoimmune inner ear disease, Paget's disease, and presbystasis can cause vertigo. The other causes for vertigo include the cervical vertigo, which could be because of neurovascular, neuromuscular, or mechanical vascular causes. We could have the ocular vertigo, which could be a result of a refractive error or palsy of the extraocular muscles. Iatrogenic vertigo could be caused by surgeries such as stepilectomy or cholesteatoma or any other surgeries which affect the inner ear. There could also be drug-induced vertigo caused by the ototoxic drugs. Psychogenic vertigo is usually caused by anxiety, panic disorders, or phobia, and the diagnostic feature of psychogenic vertigo is as you evaluate, you will not be able to find any organic cause, and there will be vague, fleeting symptoms. There will be usually a dramatic presentation, and the person will have attention-seeking behavior, and there will be a specifically there will be a relation between the emotional stress and onset of vertigo. Now, vertigo-like symptoms include faintness, lightheadedness, unsteadiness, motion intolerance, imbalance, and floating sensation. So, what causes these vertigo-like symptoms? It could be due to hematological causes such as anemia or polycythemia, cardiovascular causes such as orthostatic hypertension, cardiac failure, cardiac arrhythmias, and the carotid sinus syndrome, metabolic causes like diabetes mellitus, hypoglycemia, hypothyroidism, chronic renal failure, and alcohol intoxication. Now, based on the clinical description of the dizziness spell or the vertigo spell, how do we arrive at a differential diagnosis of vertigo? In BPPV, there are transient triggered episodes of vertigo caused by dislodged canaloliths in the semicircular canals. In vestibular neuronitis, there will be spontaneous episodes of vertigo caused by inflammation of the vestibular nerve or labyrinthine organs, usually from a viral infection. So in Meniere's disease, there are spontaneous episodes of vertigo associated with unilateral hearing loss caused by the pressure of the endolymphatic fluid in the inner ear. In otosclerosis, you have spontaneous episodes of vertigo caused by abnormal bone growth in the middle ear, and it is associated with conductive hearing loss. So what you need to remember here is in BPPV, there are transient triggered episodes of vertigo, whereas in vestibular neuritis, in Meniere's disease and otosclerosis, there are spontaneous episodes of vertigo. While vestibular neuritis usually results from a viral infection, Meniere's disease is associated with fluctuating hearing loss or on unilateral hearing loss, which could later on become even bilateral. Otosclerosis is usually associated with conductive hearing loss. So in otosclerosis, it's the hearing loss which first occurs, followed by the spontaneous episodes of vertigo, that is when it becomes a cochlear otosclerosis. Whereas in Meniere's disease, it is the spontaneous episode of vertigo which is associated, the spell of vertigo is associated with the hearing loss. In vestibular neuronitis, there will be no auditory symptom. The central causes of vertigo include vestibular migraine, then you have the cerebrovascular disease and the cerebellopontine angle and the posterior fossa meningiomas. In vestibular migraine, typically you will have the spontaneous episodes of vertigo which is associated with the migraine headaches. Now, patients may not complain of headache at all the time, but they may have a feeling of some kind of an uneasiness, some aura kind of feeling, and they'll develop vertigo. And typically they will be able to predict as they keep on getting these spells, they'll be able to predict that they're going to get this spell of vertigo. Now, in cerebrovascular disease, there will be continuous spontaneous episodes of vertigo which are caused by arterial occlusion or insufficiency, especially affecting the vertebrobasilar system. In CP angle tumors or the posterior fossa meningiomas, there will be continuous spontaneous spells of dizziness, and in psychiatric disorders or psychogenic vertigo, the spell will be initially episodic and then it becomes continuous without another organic cause, and it is usually associated with psychiatric conditions such as anxiety, phobia, depression, or bipolar disorders. When vertigo is medication induced, there will be continuous episodes of dizziness and we'll be not able to find any cause for it, and it is associated with a possible medication adverse effect. Cardiovascular or metabolic episodes of vertigo are acute and they do not have any triggers. In orthostatic hypotension, which causes vertigo, one will have again acute episodic symptoms associated with a change in position from supine or sitting to standing. Now, history taking can diagnose over 80% of the cases of vertigo. So it is very important to spend time and get a detailed history whenever a person presents with dizziness or imbalance. So let us look at the important questions that one needs to ask while taking a history. So we need to confirm whether the person is really having vertigo. So ask if it is a rotatory sensation wherein the person is experiencing himself, rotation of oneself or rotation of the surroundings, and ask if there is any syncope, something like a blackout, or if the person is feeling lightheadedness. Ask for the mode of onset, whether it was sudden in onset or gradual, whether it was episodic, that is, whether it is an isolated spell of vertigo or it's recurrent vertigo spells, or whether it is continuous. You need to ask for the duration of each episode and what are the associated symptoms, what are the provoking factors or the aggravating factors, and get a history of any other systemic illness which could be responsible for the causation of vertigo. We need to also ask about the associated symptoms. If the person also complains of decreased hearing, we need to find out if it is symmetric or asymmetric, whether there is ear discharge, whether the person has had a history of tinnitus or oral fullness, whether associated with nausea and vomiting, whether also there is imbalance. Now, if there is vertigo, which is associated with hearing loss, tinnitus, and a feeling of oral fullness, it could most probably be due to Meniere's disease. Vertigo associated with a feeling of imbalance, no auditory symptoms, usually is vestibular neuronitis. Acoustic neuroma, of course, can cause auditory symptoms, but more of feeling of imbalance could be the vestibular neuronitis or acoustic neuroma. Headache could be migraine or acoustic neuroma. Focal neurological findings, if there are focal neurological findings, most often it will be acoustic neuroma or there could be central vascular causes. If the vertigo is also associated with ear discharge, one has to rule out labyrinthitis or perilymph fistula. Let's look at the provoking or the aggravating factors. Now, whether the vertigo occurs with specific positions of the head, whether it occurs when the person suddenly stands up from the sitting position, whether it is associated with sudden head and neck movement, whether it is also associated with recurrent upper respiratory tract infection. So, if trainees are around, you can just tell me if the vertigo occurs with sudden movements, change in position of the head, what could be the cause? Can you please type in the chat box? Okay. Sudden standing up from sitting position is usually orthostatic hypotension. Sudden head and neck movement. Sudden head and neck movement. It could be cervical spondylosis. It could be vertebrobasilar insufficiency. Recurrent upper respiratory tract infection. Recurrent vestibular neuronitis is the right answer. And trauma to the ear or head. Trauma to the ear or head, it could be temporal bone fracture. Again, it could be long standing, somebody is bedridden, it could be again BPPV, again can be caused by trauma. Stress usually is because of stress associated with vertigo is usually, of course, anybody who has vertiginous spells can get stressed out and anxious, but stress usually is psychogenic vertigo. If there's headache associated with nausea, vomiting, and vertigo, usually migraine. Diplopia is seen in diplopia with vertigo. Yes, could be any neurological issues like uh, acoustic neuroma or any other neurological condition, cerebellar lesions. So whatever I have said, I have just listed it here. Yes, change in ear pressure is what we did not discuss. Usually it is perilymph fistula. Yes. So change in head position, as you all rightly said, could be BPPV, labyrinthitis, or multiple sclerosis. Sudden standing up from sitting position or static hypertension. Sudden neck movement, you said cervical spondylosis or vertebrobasilar insufficiency. Recurrent URI, vestibular neuronitis. Stress could be psychogenic vertigo, migraine, change in ear pressure, perilymph fistula. So this slide is just showing listing. It's not all encompassing. Some of the drugs which could cause vertigo, and these could be alcohol, antihistamines, anti-angina drugs, anticoagulants, INH, anti-malarials, analgesics, particularly opiates, antihypertensives, antiarrhythmics, aminoglycosides, rifampicin, and corticosteroids. Now, systemic illnesses which could cause vertigo are hypertension and hypotension, hypoglycemia, epilepsy, brain infection, brain tumors, Parkinsonism, and multiple sclerosis. Now, based on the duration of the vertiginous spell, the causes of vertigo, you need to ask what is the duration of the vertiginous spell. So, a vertiginous spell lasting for just few minutes could be benign paroxysmal positional vertigo or perilimb fistula. If it's lasting for up to 1 hour, then it could be central vascular causes or again perilimb fistula. If it's lasting hours, Meniere's disease, acoustic neuroma, perilimb fistula, central vascular causes or head trauma. Lasting for days could be vestibular neuronitis, multiple sclerosis, perilimb fistula, or central vascular causes. Weeks, vertiginous spell lasting weeks is usually psychogenic vertigo. So, vertigo spell lasting for few seconds and not associated with hearing loss is usually because of benign paroxysmal positional vertigo. If there is hearing loss, we'll have to think of perilymphatic fistula or cholesteatoma. Vertiginous spell lasting minutes, it could be vertebral or basilar artery insufficiency or migraines when also associated with hearing loss. Lasting for hours, if there is hearing loss, if there is no hearing loss, it is vestibulopathy. If there is hearing loss, it could be Meniere's disease. Vertiginous spell lasting for days without hearing loss, usually due to vestibular neuronitis. With hearing loss, one has to think of labyrinthitis. Vertiginous spell lasting for weeks without hearing loss could be because of central nervous system lesions, Lyme disease, or multiple sclerosis. With hearing loss could be because of acoustic neuroma, autoimmune inner ear disease, or psychogenic vertigo. So, based on the onset of symptoms, how do we evaluate a person with vertigo? If the symptom of vertigo has been gradual in onset and there is associated hearing loss or tinnitus, which is usually most probably due to a cerebellopontine angle lesion. If there is symmetric auditory function also affected, gradual onset with symmetric involvement of the auditory function, it could be because of ototoxicity or presbystasis. Now, if the symptoms are sudden in onset and it is an isolated episode, so if it is an isolated episode, one needs to ask for a history of trauma. If there is a history of trauma, which could be either penetrating blunt or barotrauma, one has to go for a temporal bone high resolution CT scan, and if there is a fracture, the fracture is the cause for the vertigo. If there is no fracture, then it could be because of the labyrinthine concussion or perilymphatic fistula. If there is no history of trauma, one has to look at the duration of the vertigo. If the duration is less than 24 hours, it could be because of cholesteatoma fistula or perilymphatic fistula. If the duration is more than 24 hours and there is no hearing loss, it most probably because of viral neuronitis, that is vestibular neuronitis or herpes zoster oticus. If it is more than 24 hours and there is associated hearing loss, it could be because of herpes zoster oticus, labyrinthine infarction, or labyrinthitis, that is, which could be either autoimmune or it could be infective, that is suppurative or serous labyrinthitis. So, if there is sudden onset of recurrent vertigo, that is, it's been coming on and off, and the duration of vertigo is less than 5 minutes, short spell, it's most likely BPPV, perilimb fistula, superior canal dehiscence, otosclerosis, or labyrinthine fistula. If the spell is more than 20 minutes and less than 24 hours, it could be because of Meniere's disease, syphilis involving the inner ear, or autoimmune inner ear disease. Now, the novel approach for determining the probable etiology of dizziness as given by Munshi HL and his colleagues is called as the titrate approach, where ti means that we use the timing, the trigger factors which provoke the vertigo, and targeted examination. So titrate stands for timing, triggers that provoke the symptom, and doing a targeted examination. So now what Munshi et al. Reported in their study was that wherever senior citizens were involved, their medications were responsible for dizziness in more than 20% of the senior citizens. So let's go on with this titrate approach. So when a patient presents with dizziness or vertigo, one has to look at the timing. So the first thing is timing. So is it episodic or continuous? So if it is episodic, is it triggered or is it spontaneous? So we go for the trigger factors. So the trigger factors is if the symptoms are more with movement, and one is not able to determine whether etiology is peripheral or central, then one has to go for the Dix-Hallpike maneuver. If the Dix-Hallpike maneuver is positive, it is benign paroxysmal positional vertigo. Now, if the Dix-Hallpike maneuver is negative, assess for orthostatic hypotension. Now, if episodic vertigo is spontaneous, that is, there is no trigger factor. If it is associated with hearing loss, most likely Meniere's disease, associated with headache, most likely vestibular migraine, associated with psychological symptoms, most likely psychogenic vertigo, which could be a panic attack or some other psychiatric condition. No, if the vertigo spell is continuous and it is associated with, we need to ask if it is associated with trauma, toxins, or is it spontaneous. So if it is associated with trauma or toxin, it could be either barotrauma or medications. If it is spontaneous, then one has to do the hints examination. We'll go into the details of the examination. So the hints comprises of head impulse, nystagmus, and test of skew. So when you do the hints examination, if saccades are present, they are unidirectional and horizontal nystagmus. There is a normal skew test, most likely peripheral etiology. So presence of saccades, unidirectional, horizontal nystagmus, and normal test of skew is peripheral etiology, most likely vestibular neuritis. If there are no saccades and nystagmus is vertical, torsional, or gaze evoked and it is bidirectional, and there is also an abnormal test of skew, it is most likely central etiology, that is stroke or transient ischemic attack. So this is something you need to remember. So whenever there is unidirectional horizontal nystagmus, one has to think of peripheral etiology. Whenever there is vertical nystagmus and it is torsional or it is gaze evoked and it is a bidirectional nystagmus, one has to think of central etiology. So let us go into the examination, the clinical examination of a patient presenting with vertigo. So any patient presenting with vertigo, one has to do a detailed ENT examination followed by ophthalmological examination. Check the blood pressure, check for orthostatic hypertension, cardiac evaluation, and neurological examination. So the routine evaluation of a patient of vertigo in the ENT OPD comprises of, yes, the hints, then the head shake test, and then you have the positional test, the positioning test, fistula test, caloric test, test for disequilibrium, test for coordination, and then the cranial nerve examination. So let's look at a video of how the head impulse test is done. So you'll have to gently turn the head to each side multiple times, at least 2 to 3 times, and observe for nystagmus. So next is the rapid head shake test. Now, before you assess for nystagmus, one also has to check for ocular alignment, whether the eyes are aligned or not. Only then you will be able to look for ocular alignment. Flash the light and see. Reflection of the light. So check if the alignment is maintained, and that will help us assess the nystagmus better. So the hints examination, apart from what I showed you, there's a video on this site, and I'll also share it with you later on. So this is the link to those videos. Now, nystagmus, as you all know, is involuntary rhythmic oscillatory movements of the eye, and vestibular disorders cause jerk nystagmus with slow and fast phases. The direction of nystagmus is given by the fast phase, and vestibular nystagmus gets enhanced by looking in the direction of the fast phase and is diminished by looking away from it, as per Alexander's law. So vestibular nystagmus will get enhanced by looking in the direction of the fast phase, and it gets diminished by looking away from it. Now, Alexander's classification for grading the intensity of the nystagmus, there are 3 degrees. 1 degree when it is present only while looking at the fast phase, 2nd degree when it is present while looking towards the fast phase and also while looking straight. 3rd degree is while looking towards the fast phase, looking straight, and also looking towards the slow phase. So, in vestibular lesions, nystagmus will get suppressed by optic fixation and will get enhanced by removal of optic fixation. So, how do we remove the optic fixation? By observing for the nystagmus in dark or by Frenzel's glasses. In irritative vestibular labyrinthine lesions, nystagmus will be seen on the same side of the lesion. In paralytic vestibular labyrinthine lesion, there is nystagmus to the opposite side of the lesion. Now let us look at the characteristics or the features of peripheral and central nystagmus. So in peripheral lesions, the nystagmus, the direction is fixed, its duration is short, so there is fatigability. On optic fixation, it is inhibited, latency is present, the imbalance is mild, there will be severe nausea and vomiting, deafness and tinnitus are quite common, neurological deficits are rare. Whereas in central nystagmus, it's usually direction changing and the duration is long. The, on optic fixation, it remains unchanged and latency is absent in central nystagmus. Whereas imbalance is severe in central lesions, nausea and vomiting can be variable, deafness and tinnitus, depending upon the area of the central nervous system involved, could be present or absent. Neurological deficits are very common in central lesions. Now, let us look at the nystagmus that is seen based on the canals that are involved. So, if there is right horizontal canal excitation, there is horizontal nystagmus to the left. If there is left horizontal canal excitation, there is horizontal nystagmus to the right. So, right superior canal excitation will cause upbeating torsional nystagmus towards the left. Left superior canal excitation will cause upward and torsional nystagmus to the right. Right posterior canal excitation will cause downward torsional nystagmus to the left, and left posterior canal excitation will cause downward and torsional nystagmus to the right. So here you need to remember that when the superior canals are excited, the nystagmus is also it is upbeating, whereas in posterior canal the nystagmus is downbeating, and in horizontal nystagmus the nystagmus is horizontal. So torsional nystagmus is a feature of the superior and posterior canals. So this is the same thing, again represented diagrammatically, so I will not be repeating it. So this is on the tabular column. In case anybody wants, we can take a screenshot of this slide. So if the right lateral semicircular canal, it is right horizontal. The direction of the fast phase will be right horizontal. Left lateral semicircular canal, left horizontal is the direction of the fast phase. Right superior canal, downbeating counterclockwise. Left superior canal, downbeating clockwise. Right posterior canal, upbeating counterclockwise. Left posterior canal, upbeating clockwise. So this is how the nystagmus appears. Now, other eyeball movements that uh, one can observe are, which will be nystagmoid movements, are opsoclonus, which is non-rhythmic bizarre eye movements seen in brainstem and cerebellar pathology. Ocular flutter is a mild form of opsoclonus which lasts for few seconds. Ocular myoclonus is pendular movement of the eyeball with rhythmic movement of the soft palate and tongue. Ocular bobbing is irregular, abrupt, downward jerks seen in central nervous system lesions. Now, how do we do the testing for spontaneous nystagmus? The patient's eyes are examined with the patient first looking straight ahead with the head fixed and no visual or vestibular stimulus. There is no optic fixation. It is best to examine in a dark room with infrared video goggles over open eyes, or during these days we don't do electron nystagmography, we do video nystagmography with eye closed. Spontaneous nystagmus is seen in unilateral peripheral vestibular lesions. Now, these are the infrared video goggles with which one can observe nystagmus. The next thing you need to know is the test for the gaze evoked nystagmus. So, the finger is kept centrally at a distance of 30 centimeter from the patient's eye and moved in both horizontal and vertical planes. The patient is asked to follow the finger of the examiner with his or her eyes, and the displacement from the midline should be kept to a maximum of 30 degree. So, why 30 degree is to avoid the physiological endpoint nystagmus. Bidirectional vertigo is usually seen in central nervous system lesions. The next is the positional nystagmus. So one has to place the patient's head in different positions to detect the response to changes in direction of the gravitational force. So there are 11 specific positions that one has to check for nystagmus. So sitting position, 5 head position, and in the supine position, 6 head positions. We will go into the details in the next slide. Each position has to be maintained for 30 seconds and one has to check for the nystagmus. So the sitting position will be with the head upright, right side down, left side down, head extended and head flexed. Now in the supine position, again it will be head straight, right side down, left side down, head hanging with the right turn, head hanging with the left turn. So these are the positions in which one will have to examine for nystagmus. Next is positioning nystagmus, which we commonly, the test that we commonly do is the Dix-Hallpike maneuver, and this test helps to detect the anomalies in the otolith system. So one has to provoke nystagmus by placing the head rapidly in different positions. So the tests are Dix-Hallpike test and the roll test. So the Dix-Hallpike maneuver, also called as the Nyland-Barony maneuver, is I think all of you can see the YouTube video of how to do the Dix-Halpike maneuver. Patient is kept sitting on a couch looking ahead and with the head turned 45 degrees towards the diseased ear. The patient is moved rapidly into the supine position with the head hanging 30 degrees below the couch and the eyes are observed for nystagmus for 1 minute. The patient is moved rapidly back into the sitting position and then the maneuver is repeated for the opposite ear. The roll test is done for lateral canal VPPV. So this is called as the supine roll test, where the person is first put on supine position and then asked to roll to the right, again placed back to the supine position and then turned to roll to the left and then brought back to the supine position. So one has to watch for nystagmus at every step. Now this is the video nystagmography standard goggles with the battery pack. This is actually used for observing the nystagmus when you are doing these Dix-Halpike and the supine roll test. This is basically having a glass of plus 20 diopters. So one could also do a video recording. So this is seeing it on the computer screen. The next thing is the caloric irrigation test, where one can use either open loop water, closed loop water, or cold air. So the contraindications for the bithermal caloric test include the external auditory canal obstruction, ear infection, perforation of the tympanic membrane, bradyarrhythmias, and labyrinthine sedatives for 24 hours. So how do we do the caloric stimulation? First, we have to know the principle of the caloric test. So once we use the water in different temperature, there is a temperature gradient. So there is formation of convection currents in the endolymph. So there is ampulopetal flow for warm water and there is activation of the vestibulo-ocular reflex. There is ampulofugal flow for the cold water and hence there is inhibition of the vestibulo-ocular reflex. So vertigo with horizontal nystagmus, that is the slow phase away from the side of the vestibulo-ocular reflex activation and towards the side of the inhibition of the vestibulo-ocular reflex inhibition is seen during this test. So what happens is once irrigation with warm water is done, the endolymph rises and hence there is increased firing. So with cold water irrigation, the endolymph falls and so there is decreased firing. So this is, you all will remember the mnemonic cows, that is cold water causes stimulation, cold water causes nystagmus to the opposite side while warm water causes nystagmus to the same size. So here irrigation of the right semicircular canal with the warm water, we are showing the direction of the slow phase of the nystagmus in this picture. So this is with the cold water, the direction of the slow phase nystagmus. So how it is done? The patient is put in the supine position with a 30-degree head end elevation. Each ear is irrigated for 40 seconds in turns with warm water first at 44 degrees centigrade and then with cold water at 30 degrees centigrade. The duration of nystagmus from the start of irrigation to the end point of the nystagmus is noted. So normally it is 90 to 140 seconds. So you have to, as per this, we already discussed this, cold water causes stimulation to the opposite, nystagmus to the opposite side, whereas warm causes nystagmus to the same ear. Now, can anyone tell me what is seen here? This is the cold water response. This is the warm water response. Left ear, right ear, left ear, right ear. So what you see is the duration of response in the right ear, irrespective of what is being stimulated, duration of response to cold water in the right ear is less, right? So here what you're seeing is The duration of nystagmus with both 44-degree and 30-degree irrigation in 1 year is 30% less than the other year. So this is seen in the same-sided peripheral vestibular lesion, and this is called as canal paresis. So what you're seeing, this is the calorigram. You're seeing the response to both cold and warm stimulus is less in the right ear. So here you're seeing left canal paresis. So there is duration of response is less in the left ear to both cold and warm stimulus. So in directional preponderance, what you see is there is duration of nystagmus in one direction is 30% more than the opposite direction. So seen in same-sided central vestibular lesion and opposite peripheral vestibular lesion. So what you're seeing here is the right directional preponderance. So right. And here you're seeing the left directional preponderance. So now we need to understand this. There are some special cases where there can be same side canal paresis and same side directional preponderance. That is seen in acoustic neuroma. Same side canal paresis and opposite side directional preponderance is seen in Slenius disease. Now, many of us will be called to do caloric test in the brain dead or in the comatose patients. So, in such patients, if there is an intact brainstem, only slow phase movements will be seen to cold or warm irrigation, and the fast corrective phase will be absent. If there is bilateral medial longitudinal vesicle damage, internuclear ophthalmoplegia seen in multiple sclerosis, only lateral movement of one eye is possible as bilateral medial rectus muscles are denervated. With bilateral lower brainstem lesions at the level of the vestibular nuclei, there will be no nystagmus with either warm or cold water irrigation. Now, a modified Cobrax test is a test where the external auditory canal is irrigated for 60 seconds with ice cold water in increasing quantity, that is 5 ml, 10 ml, 20 ml and 40 ml till the nystagmus is noticed. So if nystagmus is noticed with irrigation of just 5 ml of ice cold water, it means that the vestibular labyrinth is normal. If it is seen with 10 ml, 20 ml or 40 ml, it means there is a hypoactive labyrinth. If there is no nystagmus even with 40 ml of ice cold water, it means there is a dead labyrinth. So more commonly with the video nystagmography, we use the cold air caloric test, and this can be the advantage of this is that it can also be done in patients with a perforation of the tympanic membrane where syringing with water is contraindicated. So air in the coiled copper tube is cooled by pouring ethyl chloride in it, and effluent cold air is blown into the external auditory canal to produce vertigo and nystagmus. Now let's go on to the tests for disequilibrium. These include the standing test, the tandem gate test, Romberg test, modified Romberg test, the Unterberger test, and the Babinski wheel test. So in the standing test, the patient has to stand normally with the eyes closed. And when patient stands that way, you will see that if there is a peripheral vestibular lesion, the patient will assume the discus thrower's position. That is, the head will be turned towards the side of the lesion, the trunk will be distal to the side of the lesion, and the hand on the healthy side will be raised, and there will be lowering on the hand on the side of the lesion and falling towards the side of the lesion. So this is the discus thrower's position. Tandem gait test, where a patient is made to walk with eyes open in a straight line in tandem position. That is, the toes of one foot are right behind the heel of the other foot. It is stopped suddenly and then the patient is asked to walk back, and the test is repeated with eyes closed. There is falling towards the side in the peripheral vestibular lesion. So this is tandem gait test being done. Next is the Romberg test, where the subject is asked to stand with feet together, eyes open and hands by the sides for 1 minute, and one has to observe for sway. Subject closes the eyes in the same position for 1 minute and one has to observe for sway. Now, Romberg test is sharpened by the tandem position of the feet. Now, there is swaying towards the side of the lesion only when eyes are closed. It is called as a positive Romberg, and that is seen in sensory ataxia, where there is loss of proprioception. So, negative Romberg, that is swaying even when the eyes are open, is seen in cerebellar ataxia. So, here you are seeing the Romberg's test being performed. In the Unterberger test, the patient is blindfolded, the arms are extended, and patient is asked to step on the spot 90 times in 1 minute. In peripheral vestibular lesion, the patient will deviate or rotate towards the side of lesion by more than 30 degrees. If it is less than 30 degrees on either side, if the deviation is less than 30 degrees, it is considered to be normal. So here you're seeing the Unterberger test being performed. In Babinski-Wheel test, patient is asked to walk with the eyes closed, 5 pace forwards and 5 pace backwards, 6 times in 30 seconds. So, in a unilateral vestibular lesion, you will see that the patient walks in a star-shaped trajectory. Now, tests for coordination are the test for pass pointing, the Fukuda writing test, the test for cerebellar function, which include the finger nose, heel knee, and the rapid alternating task test. So, patient is made to sit with the hands up and the index finger extended, and the examiner raises his finger in front of the patient, and the patient is asked to touch the examiner's finger with eyes open and then touch the tip of his nose. And this is done with both eyes open and eyes closed. So, if the patient cannot perform the task smoothly, that is called as pass pointing. The Fukuda writing test is where the patient is asked to write 8 to 10 capital letters vertically in a straight line first with eyes open and then with eyes closed. In unilateral vestibular lesion, the letter deviates more than 20 degrees towards the involved side, but the letters are legible. In cerebellar lesion, the letters are illegible. This is the finger nose test. In cerebellar lesion, the patient cannot do it. There will be past pointing. Heel shin test, the patient is asked to move heel of one leg over the shin of the other leg in a straight line, and patient will not be able to do it in the cerebellar lesion. The next is the asking the person to perform rapid alternating tasks, that is supination and pronation of one palm over the other palm at a rapid rate. One cannot do it in the cerebellar lesions or has difficulty in doing it, that is dysdiadochokinesia. So here you're seeing the knee or heel shin test being done, and this is the test for dysdiadochokinesia. So an evaluation for vertigo is incomplete without evaluation of the cranial nerves. So one has to evaluate all the cranial nerves. Now, other specific investigations, because today we are covering only the clinical evaluation, I will not be going into these investigations. I will be stopping at this. In the next session sometime, probably we will cover video nystagmography and all these tests in detail. So specifically video nystagmography, I would need a separate session for it to teach you the various patterns and other things. So these are the various investigations that are done, and more commonly in our setting, in my hospital, we do video nystagmography. We do some of the vestibular rotation tests. We do vestibular evoked myogenic potentials and dynamic visual acuity. So very commonly, most settings, video nystagmography is done, and hence all of you should learn how this test is done and its interpretation. So with that, I come to the end of this session. Thank you very much. Okay, somebody is asking how video nystagmography is better than the clinical test. Clinical evaluation, most of your, more than 80 to 90% of your cases will be able to arrive at a diagnosis. A video nystagmography helps you to visualize the various eye movements better, the tracking, the various graphs will be seen better, and you will be able to see, even after the test is done, you will be able to go through each and every, the movement, and then you will be able to evaluate and arrive at a proper diagnosis. So it helps in recording the movements, because when you are actually doing the clinical test, you will see it, but you will not be able to record So when you do the video nystagmography, you'll be able to record and you'll be able to review it. And based on that, you will also be able to plan the, the corrective maneuvers or the treatments, whatever the rehabilitation and other things. Thank you very much.
Ma'am, scroll down. There is one more comment in the chat box.
I'm not able to see any question. Can you read out the question? Because I'm not able to see the chat box.
Now, can you see at the right bottom of the chat box?
It's not seen.
No issues. So, Dr. Najila is asking for the BP PV management.
Okay, that is a session in itself because I'll have to show all the maneuvers and other things, so that can be covered, I think, in a different session.
Excellent. So
Yeah.
we have there are, I think, no more questions. Thank you very much, Professor Dr. Vijayalakshmi Subramaniam, for the presentation, and thank you very much, trainees, for joining.